Okay, we're going to talk about some pituitary disorders. This is also chapter 48 in your Ricci textbook. Who's this dude? So he is the most famous that I can think of now, person with hypopituitarism or growth hormone deficiency, which can also be known as dwarfism. And if you remember, Hezbollah has growth hormone deficiency. You should be able to put together a pretty good mental picture of what it looks like. And this is him as a full-grown adult. So hypopituitarism is a primary anterior pituitary disorder, which means it's not caused by anything outside or an external factor. The definition is that the definition of the pathology is that it's the anterior pituitary that fails, or the hypothalamus doesn't stimulate the pituitary to produce growth hormone, which is why it's simple to remember it as a growth hormone deficiency. It tends to affect like 1 in 4,000 children, so that's quite a bit. So these are some of the cues, and I've given you a picture of two little girls as well, so that you can see that Hezbollah, who is literally an adult, has very similar features to both of these little girls. They have a chubby, rounded face with a lack of a nasal bridge. Large forehead, and the majority of their facial features are very centralized and infant appearing. They normally, these kids would be born, they'd be normal sized. They'd be a normal sized kid at birth, and then over time they develop short stature. So usually once they start assessing the growth patterns, their birth weight and length is normal, and then by the time they make it to the first few years of life, they're less than the 3rd percentile. So they could have been at the 50th percentile on a growth chart at birth, but by age 3, they're going to be less than the 3rd percentile. They have abdominal fat deposits, so chubby bellies, just like we expect a little one, a child, to have. They have childlike angelic faces with large foreheads, small nose bridges, and they have delayed dental eruption, so their teeth tend to come in really late, and this can cause some issues in their mouth and with the shape of the roof of the mouth. They have decreased muscle mass overall because muscle mass is related to growth hormone, and they have decreased skeletal growth. They end up with delayed sexual maturity and usually have a higher pitched voice. We also see some laboratory changes as well. So some of the diagnostics that we're going to use is a bone age. So we're going to do a bone survey, just like you would on a woman or man to determine if they have osteoporosis. So a bone scan will show that they are 2 deviations or more below the normal for their age. So let's say, for instance, a coroner was looking at the bones of a child with growth hormone development or growth hormone deficiency, and they didn't know how old the child was. They would assume that they were at least 2 years or more younger than they actually are. We would do a CT and an MRI to rule out any tumors like pituitary tumors or any structural anomalies. And then pituitary function tests confirm the diagnosis. And those are done by administering different medications like insulin or arginine, clonidine, or glucagon. And then we do blood sampling at specific times throughout the testing, and we look for the peak levels to be below 7 to 10 nanograms per deciliter, and that is indicative of a growth hormone deficiency. During a pituitary function test, we have to keep the kid in PO, and we have to monitor their blood glucose levels during the study and watch them for signs and symptoms of hypoglycemia. And then at the end of the test, we're going to give them some simple sugars. So just like candy or orange juice or something. I told you that there was some laboratory involvement with this. We're going to see these kids have hypoglycemia. They're also, because of their lack of growth hormone and their pituitary anomaly, they frequently have electrolyte imbalances and an inability to metabolize proteins, fats, and carbohydrates. Because of that, that's why we end up seeing them have such serious hypoglycemic episodes prior to being diagnosed. Some of the medication that we use, one of them is called literally supplemental growth hormone, which is somatropin, and we give it at 0.16 to 0.24 milligrams per kilogram per week. And we get that weekly amount because it's going to change every week based on their weight, right? So we get the weekly amount and then we divide it into equal doses and we give it once a day. So I need you guys to know that we're going to, as nurses, inform the family that injections of somatropin are given until, and the general rule of thumb is until the child is happy and satisfied with the amount of growth that they've had. We need there to be a decent understanding of the management of their own expectations. So if they have a child who's the size of Hezbollah, they cannot expect that child to receive growth hormones until they are the size of Kobe Bryant. Their child is likely not going to play pro basketball. So we need them to manage that expectation. We want to promote the child's own sense of self-worth and self-esteem, and that's part of the reason why the child should be involved in the discussion of when to stop the somatropin. We have to monitor and teach families how to monitor blood sugar levels, electrolyte levels. We advise the family on the administration of the medication and how it's given, how to do the injections, how to rotate the sites. And then we want to make sure that they're watching for any deleterious symptoms like headaches, super fast weight gain, polydipsia, polyuria, and painful joints. All of these things might indicate that the somatropin might need to be decreased in the dose, or that the child needs to be evaluated for the potential of some sort of tumor. We want early diagnosis and treatment, and that means they have a better prognosis for getting to a normal adult height. Like I said, treatment either stops when the epiphyseal growth plates fuse or when the child decides that it is a realistic time to be done. there are literally foundations specifically for these children. So like the Short Stature Foundation, the Human Growth Foundation. We need these kids to know that there are other people like them, but also that they can be treated as normal, because they are, if not for a health problem, which almost all of us have one. We just might not know we do. We do need to evaluate these kids for any long-term learning disabilities because, like I said, they could be developing a tumor because growth hormone doesn't only grow exactly what we want it to grow. Administration of growth hormone during your formative years can cause tumors to grow, can cause structures to grow that shouldn't grow. So we need to watch for those possible complications. And then we need to assist the family with getting financial assistance because growth hormone therapy isn't cheap. Not every insurance company covers it. But it is really kind of necessary. We also want to tell them how to have good nutrition because these kids don't metabolize carbs, proteins, and fats the way that they should. So really promote great nutritional intake. And they always need to be on the lookout for the potential of developing diabetes, which is part of the reason why we're monitoring them for polydipsia, polyuria, headaches, and increased weight gain. It's not just tumors, it's also diabetes. These are some of the complications of growth hormone deficiency. Hypoglycemia, diabetes, a condition called slipped capital femoral epiphysis. So basically like the epiphysis of the femur kind of slides out of place and it causes them to have an unmanageable limp. They can develop pseudotumors, leukemia, because again, growth hormone, central nervous system tumors, because again, growth hormone, and infections related to the injections that they're receiving. And then a lot of them will develop sodium retention and or edema. Now we're going to talk about precocious puberty. It's an interesting one, so buckle up. All right, so precocious puberty, you can find information about it in your Ricci text on page 1784. Basically, it is when a child develops sexual characteristics before the usual age of puberty. So for girls, age, I don't know, 10 to 12 tends to be a pubertal onset. This would be a little girl developing sexual characteristics prior to age 8. For boys, it's age 9 because they normally go into puberty between like 11 and 14. The pathophysiology of this is that it's premature activation of the hypothalamic pituitary gonadal axis. Basically, the gonadotropin releasing hormone, or GnRH, stimulates luteinizing hormone and follicle stimulating hormone, which then stimulates the gonads to secrete sex hormones, which are estrogen and testosterone. It is unfortunate for these children because not only are they developing sex characteristics at an age that's far too young, you can see obvious breast development on this little girl whose face and shoulder structure appears to lead me to believe she's probably around 4 or 5, maybe 6. And then this little boy, if you look at him, oh my goodness, his scrotum is massive. His penis is massive. He probably has a deep voice. He's growing hair in places he shouldn't have it. Like, his armpits and his groin, and he is just confused. So the problem is that they can reach sexual maturity at too young of an age, meaning that this little girl could literally be fertile and be able to be fertilized by this little boy. They also achieve skeletal maturity too soon, which means their epiphyseal plates close. So it happens so early in life that then as an adult, they're too small. So they look like they have dwarfism, but they don't. So this is precocious puberty. Some of the clinical manifestations. We have headaches, nausea and vomiting because of crazy amounts of circulating hormones. Visual disturbances also because of the circulating hormones that shouldn't be there. Emotional lability, aggressive behaviors, mood swings, acne, body odor, and accelerated growth up to a point. So the problem with all of these things is that this is a child who is basically going through everything we remember from puberty at too young of an age, and they are unable to understand why or even to deal with the feelings involved in it. So there's going to be a lot of social issues, and it's disturbing for families and family members. So just think of everything about you when you went through puberty and how horrible it was, and then try to imagine that all happening at age 5. So the management of precocious puberty, the very first thing is determine what's causing it and then treat it. We can give the gonadotropin, the GnRH analog, to stop the production of the estrogen and the testosterone. I'm sorry, the gonadotropin releasing hormone. I say it wrong every time. We can give an analog of that and it's going to stop it. We can also give medroxyprogesterone injections to the females to stop them from menstruating. So I do need to let you know that this is something that is done for reasons other than precocious puberty. Sometimes it is done to stop a child from who is otherwise normally, let's say that they have a parent has a cerebral palsy child who is nonverbal and non-mobile, and they feel that it's going to be easier for them to care for that child if they are smaller statured and they don't develop sex characteristics. So for the males, they would give them the gonadotropin hormone, and for the females, they would give them the medroxyprogesterone and or have a hysterectomy done, basically to stop them from ever having menses or puberty, and then they will also stop growing. And that's an ethical debate that occurs about whether or not it should even be allowed. But really, when it comes down to it, it is the family's choice, and we have to support the family in whatever their choice is and make sure to provide them with resources and education about that choice. Okay, so as nurses, we're going to give families education, because if their child is having precocious puberty and we start treating the precocious puberty and making it stop, Usually what the parents are freaked out about is, oh my God, my kid's never going to have a period. Oh my gosh, my child is never going to be able to impregnate someone. So they are concerned about normal puberty and normal fertility. We need to let them know that when they stop administering GnRH, when they stop administering medroxyprogesterone, normal puberty resumes according to the appropriate developmental stage or age. So our goal is just to stop or reverse sexual development and promote normal well-being psychosocially. We also educate families on the correct use of the medications. The GnRH can be given intranasally or as a depot injection, as is the medroxyprogesterone. The medroxyprogesterone, I believe, cannot be given intranasally, though. We want to monitor these children and the families for any concerns related to self-esteem. And we need to make sure that they're following up every 6 months because we want to manage the medications and the response to the medications and make sure that everything in their social lives is going okay. And that's all for this weird thing.